Care Subcommittee for MLAC. I'm very excited for today, and unless you have anything, Terry or Kim, we can go straight into provider feedback while I work in the background clicking buttons to get myself organized.
I do not have anything.
Okay.
Yeah, I don't have anything either, Emily, although I have the agenda up. And just to, kind of help you get things rolling, we have our first presenter today is Dr. Ron Bowman with Northwest Extremities, and he is a specialist, and I believe a surgeon.
Yes, I am. Shall I start
Hi,
off?
Dr. Bowman. Thanks for joining us
Yes.
today.
Well,
Yes,
thank
please.
you.
Thank you so much.
I saw this notice go through and I thought, I've been chairing the medical advisory committee for 20 years. Maybe I ought to show up and as at least a contributor for questions that come up. So I don't have a canned presentation. I just went through the list of questions that were presented. So I'll just go through that. Feel free to interrupt at any time if you have a specific question that comes up, and we'll go to the end. So yeah, my name is Ron Bowman. I went into practice in orthopedic surgery in 1991 in my hometown in Pendleton. I was there 7 or 8 years and then went to Bend for 4 years. And then I've been in Portland since 2003. Prior to coming to Portland, my percentage of workers' compensation was probably between 10 and 20%, which is typical of a general practice in orthopedics. Coming to Portland, I joined another surgeon that had a workers' compensation only practice. So that was 100% for a couple of years. And I've been generally 70 to 80% workers' comp in my practice since then. It's a little less now for other reasons, but I was Tiger Orthopedic and Fracture Clinic, and was bought out by a capital equity fund, but I'm a full-time employee for it. So we'll go right into barriers to see in injured workers, and we've got the subcategories here. In the workers' compensation system, that's kind of a general, broad subject, but several things came to mind with that. Workers are often hesitant, not always, but often hesitant to file a claim because they feel they'll be looked down upon by the peers, and then there's often sense of being overseen by the managers and bosses for ruining their 300 days of no injuries, that sort of thing. That can actually cause a legitimate delay in seeking care sometimes. With the system itself, what I hear from my patients frequently, and then from my staff as well, is there is a significant problem with adjusters not answering their voicemails and essentially ghosting issues that come before them. We can't make any progress if a decision isn't made. If it's not, a decision is made, but it's not the one we want, there are ways to handle that. But I don't know what is going on with that element of workers' compensation, but it seems that could be adjusted with some rules of some kind. And along those lines, I've had a few patients that have adjusters switched several times during their ongoing claim, and each time there's more delay in the progress on. Usually it's a controversy about what's appropriate accepted conditions for the injury and that sort of thing. And along those lines, legal involvement typically slows the speed of progress, but it's necessary in this system, and I think works fairly well. I spend quite a bit of time on the phone with one attorney or the other going through these. Paperwork. The bulk of administrative paperwork, it's all electronic now, so I don't know if we should call it something different. But that accrues following an injured worker, I think has resulted in several of my colleagues just saying they're not going to do work comp. They just don't want to deal with it. It's not just a nuisance factor, it's a business factor. Having that level of documents that need to be processed by your staff increases the overhead cost of your business. And in a office that doesn't do much workers' comp, that can be a problem where it's just better not to deal with that at all, excuse me, and just go forward with commercial insurance only. Let's see, the insurer. So there's insurers, the insurance company, and there's the MCO, and there's back and forth with those. I think you all know what that is, right? The MCO, Managed Care Organization, that handle it too. I see the ODG, or Occupational Disability Guidelines, is a set of guidelines that, if you look into it, I think was developed by the insurance industry for use by the insurance industry, is heavily biased. It's used as a reference for how many physical therapy sessions you can get, or even what surgeries you can do. I've had surgery requests denied, and I'm a board certified orthopedic surgeon. It's not a battle I want to fight, but that those kind of things, some doctors, some surgeons will say, oh, I don't want to deal with that.
Dr. Bowman, can I interrupt you for a second? I
Yeah.
have a question on something that is a common thread, so I want to get a little more information if that's okay. In relation to the bulk of, we'll call it administrative documentation, since it is digital at this point, it's no longer
Yes,
paperwork.
that's a good one. I like that.
My question is, are you finding that it's duplicative? Because there is, or how does it differ from documentation requirements from other payers, right? When you take insurance, you still have a certain amount of documentation you need to complete for whatever regulatory body or insurer you need. What makes it more for workers' comp specifically?
Well, there's quite a bit more correspondence where the, for instance, each clinic note is sent to the adjuster, and then that's distributed out to different stakeholders that are as appropriate in it. The initial demographics are similar, but then often we find the patients, the understanding of who their attending is, or who the details of their claim, whether the claim's accepted or not. If someone's making an appointment in an office for a workers' comp claim and they're not accepted yet, then that's not going to be paid. So that needs to be figured out before they come in. There was an article, fairly well done. It's old school now, but it was probably 30 years ago in the journal Bone and Joint Surgery, where they looked at the administrative costs in a 3 or 4 surgeon office for commercial versus workers' comp. Now, as you know, workers' comp is different in every state, so it's a little apples and oranges. But I recall that there was a 20% increase cost burden for the practice to handle the additional what did you call that? Administrative data?
I called it administrative burden. It's a common
Administrative burden. Okay.
Yeah. Documentation burden in general is a common thing we use in nursing. So just thought I'd share that.
Yeah, and then there's quite a bit more correspondence back and forth about when is the patient going to be medically stationary, and it's because the insurers have to put away money for anticipating a claim closure at some point. So I get the reason for it, but it's just more static that comes through the office, then surgeons are not good at wanting to do paperwork or administrative burden issues.
Thank
Yeah.
you very much.
Yeah, you bet. So, and then let's see, insurer, also many urgent clinics and first line providers are not that knowledgeable and are not that experienced in the workers' comp ins and outs and getting all the numbers correct, so that there's not a glitch in it going forward. And often that will lead to a significant delay that can be important. For a lot of what I do, it probably doesn't matter, like a rotator cuff tear that's retracted. If a few weeks or a couple months probably won't make a difference. But in something that's called like a distal biceps rupture, where the biceps tendon pulls off at the elbow, boy, we want to get those within 3 weeks, and or it becomes more difficult and more prone to complications. But it's rare for that to happen. I try to train referrers that work with me to call me here, send something so we can get around the process and get the worker where they need to be.
When you say some of the first line providers have less, I understand they have less experience in workers' comp. When you say, I think you mentioned codes, are we talking about like diagnosis codes for specific injuries that might be covered, or things that would align with speeding up the process for you to be able to treat?
Well, I've had on my intake for new patients that come in, sometimes they're 2 or 3 months out from an injury, and their MRI was just obtained last week, and it did not progress. There's a little different treatment algorithm in dealing with workers' compensation injuries versus a commercial insurance. In commercial insurance, the diagnostics are not the first thing you do. You wait along until it matters and makes a difference in the decision-making process. In workers' comp, ongoing rights, including after your aggravation rights after the claim's closed, depends on the accepted condition. So I think it's very important to get early diagnostics, pin down what the true cause of the injured worker's injury is, and proceed from there. And a lot of the first line people use the same algorithm of waiting until you have 2 months of physical therapy or whatever the things the insurance wants you to do.
That is super helpful, and that makes sense to me. So thank you for explaining that.
Yeah. And you could argue that by getting an MRI right away, that ups the cost. Well, it defines the treatment algorithm, and I think it, if anything, is a wash, and it might even be cheaper to get on with what needs to be done right away. The referrals, so that the MCOs have panels, there's a reason for that, and that should not go away. There's some enabling physicians, if there were not MCOs, you could not shut down a claim that needs to, and some of them do take on a life of their own. But that use of panels or approved doctors can be restrictive if we're trying to get a patient to a highly subspecialized provider, and it's a lot of back and forth trying to get them there. They can be overrun by a TCP or temporary credential provider, I think is what that stands for. But that can be, that's a hassle. We've talked in the medical advisory committee, we've gone over hassle factors, and that's some of the things comes up. The couple things are, it seems like it would be easy to rectify somehow, but it's often difficult to tell who the attending provider is for the patient and try to clarify that, and what their accepted conditions are. Patients don't know. They say, well, they got a letter that says it's accepted, I'm here. Well, yeah, it's accepted for a strain. Yeah, but that you haven't, you got an MRI that shows you got a meniscus tear, that hasn't been accepted. You know, that's a little hard to explain to the unknown patient, but it would be good, it seems like, to have a computer Excel file equivalent somewhere that says what that is, and you can look it up by the claim number easily. Then let's see, under injured workers, I talked about accepted conditions. Just a comment, I'd say one of the issues that comes up, and I've lived it, is in a small town, taking on a workers' compensation claim by a family practice can be problematic, because unless that's handled just right, and some people get really angry about how their claim comes out if an IME shuts them down or something, that doctor is seeing the family at church and at the Safeway. It's a small town, you can't, and it can actually hurt their practice, because most of their practice is just regular doctor things. And if the family doesn't like how it's handled, they go to somebody else. So that can be a disincentive for providers in small communities to get on. Let's see, I asked, do you meet with other providers? Well, we have the MAC meetings, medical advisory committee meetings, and we have a good discussions there 2 or 4 times a year usually. And I interact quite a bit with Northwest Occupational Medical Center. Dr. Lorber is one of the guys, so he's on the committee too. I also work with providers with Providence in the Portland area, and a couple different ones up in Salem, and they're educated and experienced occupational medicine physicians, and that's a ideal level of knowledge and capability handling workers, the claims, and they come through. But there's not enough of them to go around, I don't think. Do I have staff in my office to help with workers' compensation issues? Yes, I'm very lucky. One of my staff, Marquita, she started out her career as an adjuster. She kind of knows all the players around, and she knows the ins and outs of the requirements that can slow things down, and what we can do to try to make progress in a workers' compensation claim. I also, if something comes up that I'm unsure how to handle it, or have a question, Yuri Coons has been a good reference for me. He always knows who would be good for me to call. I may not know all the answers, but he's very helpful with that. Oh, that was question 6 too. So let's see. On the end there, I already talked about that as far as would I increase or expand it? Well, that's already what I do, so that's not going to make a difference in my practice. What we want to do is try and incentivize the in orthopedics, I can speak for them, but the orthopedic group to take on some aspects of a workers' compensation claim. When there's a patient that needs surgical treatment for some workers' compensation injury, the surgeon doesn't need to be the attending. And if they're not interested in doing that, I don't think they should be forced to do it. They won't do a very good job. They'll, but that's where it works well to have ideally an occupational physician handle the attending physician status and the communications that come up. And that's what I have. Any questions?
I was feverishly typing away. I think I asked mine all as you were speaking. Kim?
No, I see Kristen Adams has her hand up.
Sorry, had to unmute. Thank you so much. This has been a lot of great information. I had one question just sort of on the last comment you made about ways to incentivize other doctors, and particularly surgeons like you were discussing, to be more interested in doing workers' comp. And I think that's something that probably most of us on this phone are very passionate about, trying to figure out a way to do that. So I was just curious if you have any suggestions from your experience of things that, I know you've gone through a lot today, but anything in particular that you had in mind that changes that could be made or things that could be implemented to help that incentivization?
For incentivization, well, I suppose you always pay more, right? The payment is not bad now. Just don't let it, if it goes down to the same reimbursement as commercial, you'll see a lot of people drop off. Streamlining the process. So I don't know how you, I don't have ideas how you can do that. That's a tough problem, but eliminating speed bumps. So for instance, the approval for surgery process is straightforward or streamlined, particularly if the patient has commercial insurance and one or the other is going to be handling it. Right now, they have to duke it out in the legal side before they can go forward and have to deny something. But to streamline the overall process would be helpful, and it wouldn't be seen as a burden on the office taking on workers' compensation.
Okay, thank you.
Thank you for your question. Thank you for the answer. Keith, I see your hand is up.
Thank you, Keith Semple, Oregon Trial Lawyers Association. Thank you, Dr. Bowman. That was very informative. One question that has been kind of kicking around is the potential expansion of managed care organizations. I'm wondering if you find the practice more streamlined when you're dealing with managed care organizations or less streamlined?
Well, in general, it's another level of authorization that has to be done, and it's less streamlined using that. Although sometimes so the MCOs I've worked with for a long time are fairly straightforward. What they're supposed to, I think, separate it into is the MCO has access to practitioners that can look at the medical side, where just the adjusters don't have degrees in any medical care. And that can be helpful. But in general, the MCOs prolong somewhat the treatment process.
Can I ask a follow-up?
Yeah, yes.
Do you find it challenging to get MCO approval and then get a response from the insurer as to whether they'll also approve the services? Is that a sticking point?
Oh, yes. We run into that all the time.
What happens there?
Well, it depends. I mean, sometimes the MCO will deny it for whatever reason, but we talk, and then you're left, well, what are you going to do? Just follow the patient forever and hope he gets better. Then staff will talk to the adjuster and they'll approve it. It's an unusual situation, but that does come up once in a while because it's the adjuster that needs to approve it. The MCO is advisory is my understanding. I don't think they have veto power.
Can I ask just one more, please?
Yeah.
Do you think that having more MCO involvement would make a kind of an attending level physician more or less likely to take on workers' comp? In other words, do they offer something to the providers in terms of education or recruitment that a provider really might think, man, I won't do it without an MCO. I just need that.
No, I don't think I don't think the provider feels they're necessary for their practice. It's all the administrative side. I don't necessarily understand that relationship altogether. I do or have seen that there can be, the outliers. The outliers are in all segments of society are what drive a lot of these things, but they're left unchecked. There are some physicians that could carry on, for instance, off work slips for no medical reason indefinitely and use that to pressure to get what they want. And that the MCOs can help with that.
I'm sorry, can I ask just one more? We mentioned the official disability guidelines. Do you find that those are used to kind of try to drive the treatment plan away from what the doctor wants?
Yes, they're used to deny treatment.
Thank you. That's all I have.
Yeah.
Thanks. I see your hand. I'm sorry, I'm typing.
No worries. I just wanted to help clarify the question on MCO approval versus processor or insurer approval. The MCO, when looking at requests for surgery, treatment plans, et cetera, only addresses medical reasonable and necessary status and not whether it's compensably related to the injury. So that's where there's sometimes a disconnect between an MCO saying, yes, the surgery looks like it's reasonable and necessary, but if it's not for the correct condition, the insurer may say, no, never mind.
Yes, that's a good point. And I've been one of those reviewers in the MCOs that look at the charts that come in for that purpose. And sometimes the answer is this is an appropriate request, but it may not be due to the industrial injury. And that's an administrative issue.
And a lot of these questions really center around, again, the system is so complex from all different sides. What can we do to streamline it so people who are in an MCO versus not in an MCO, doctors who are within the region, who are not necessarily within the region, how can we simplify and streamline that process so everyone's getting kind of the same review, the same benefits?
Well, I don't know, that'd
easier
be
for all parties involved on all three sides.
Like a statewide sub-insurer, I guess, if it's looking for medical necessity and what it's directed to, you have to have some kind of type of a subcommittee of providers that are accessible for the adjusters to query about specific issues. Some of them get fairly complex, and it would be best to have access to educated and experienced reviewers in those cases when they do come up. I don't have a good answer for it though.
I think that's the brunt of what this committee is kind of looking at right now.
Yeah. I mean, ideally it'd be the same all over the state, right? And you wouldn't have then allegedly some of the competition among the insurers will keep the premiums down and yet maintain a reasonable payment for the providers. And that's a big mix of business stuff.
I see a hand. I'm not sure who you are. I'm assuming you are a business.
Hi, Emily. This is Giovanna
Oh,
Patrick.
hey. Hi, Shimona. Sorry. It came up
Patrick.
as
I'm sorry, I'm traveling today, so I haven't been able to change it from my business name. But if I could ask a question of Dr. Bowman, I would appreciate that.
Sure.
of course.
So Dr. Bowman, I appreciate all your comments here today and you coming to give us this insight. It sounds like the authorization and approval process is one of those sticking points or, choke points in claims. Do you think that some sort of standardized like portal level approval process where doctors could type in their information and then get approval or disapproval back in a certain number of days, something streamlined like that, do you think that would help in getting better access and getting people back to work faster?
Yeah, it might help. I understand both sides of this question or this issue, however, because if you get somebody who's got a degenerative knee and then they're walking across the parking lot and it flares up and then they come in with a meniscus tear that was probably there already. You don't want that streamlined so that gets into the system because that's a pre-existing condition. So you can't streamline it so much that everything goes through, or it'll be overused. But a way, if there was I'm just thinking out loud here, but if there was a fast track for ones that are obvious that this happened at work, there's certain, a young person, I would say the knee model, they slip and fall, twist their knee swells up. It's been documented in the contemporaneous medical records. Well, that needs to get right through. Or like the earlier example of a distal biceps rupture at the elbow, that needs to go right away. But if there's some mitigating factors, then that can be a different bucket that some of those go into, and there would be some expected delays, but at least a decision would be made, and the providers would know that and can tell the patient that or tell the family that if they're waiting for care.
Thank you. And yeah, I was thinking of maybe more along the lines of, accepted claim, you are requesting physical therapy, maybe post-surgical physical therapy. And is that ever difficult? And could that be better streamlined through some sort of,
that could use a lot of work, because I don't see why I have to every month request another twice a week for 4 weeks physical therapy for someone I just did a rotator cuff repair that's going to be at least a 4-month physical therapy problem. And what I do see people harmed by that, where the re-requesting of ongoing physical therapy, there's a glitch and it's 2 weeks before they get approved, and by then the therapist is full that they've been working with for that next week, and they've got one therapy session the week before they see me in a month for the whole month. And in shoulder cases, that can result in a adhesive capsulitis that we end up having to take them back into the operating room.
Thank you. Appreciate that. And it sounds like maybe a more streamlined process for requesting those things would be preferable for you and probably for the adjusters too, than leaving endless voicemails and waiting for calls back.
Oh yeah, it's just back and forth. That can be streamlined, I think. Another thing that comes up frequently in my progress, since I'm doing shoulders, and a lot of times it's a year or two since the injury, the the iron workers getting back to work. And so I get them in into a work hardening program. It's a 6-week program daily that gets them buffed up so they can work. Well, I have to request a work hardening evaluation because they have to be deemed that they're ready to they're appropriate for the program, because not everyone is, and they need that test. And then you get a paperwork back that says, all right, this one looks like a good candidate. He's in a light category and it needs to be in a heavy. Do you want him in the work hardening program? Yeah, that's why I sent him over. Why would I not do that? But sometimes getting that notice back and forth can be 2 weeks, and then they've got to schedule them. So there's another month getting that going, and that's all added on to the time loss curve that could be shortened if that process was streamlined.
Thank you, doctor. I do really appreciate that your office is so good at the back and forth and used to it. But do you think that back and forth and the difficulties in getting those schedules could discourage some other providers from participating more fully in our system?
Oh, yes. And then in a typical office where there's not a lot of workers' compensation handled, the staff don't know how to handle it. And they're asking each other how to do it. And it can lead to unnecessary delays. And then the patients calling saying, hey, I'm not getting what I need. And it can be difficult then for the uninitiated office to know where to look and who to call, and especially if it's something they rarely do.
Well, thank you, doctor. Those are all the questions I had for you, but I really appreciate all your insight and ideas on how we can improve the system. And thank you, committee chairs, for allowing me to ask questions.
Oh, you bet. Good luck.
Dr. Bowman, I do have a follow-up question. You had mentioned the need for like reapproval of therapy after a certain amount of time for conditions that, like, I would assume have some best practices amongst your discipline, as far as if we're talking post-surgical knee, right? We're looking at an expected 3 to 6 weeks or 3 to 6 months. There are best practices around what we would imagine physical therapy to need for recovery. And those are being hindered by insurer required authorizations. Am I understanding that correctly?
Yes, and my understanding of it is that we can do no more than 1 month. Now I'll stretch it out sometimes and put in 6 weeks and hope I get away with it. Sometimes I do. But
and in your experience, right, when you refer to physical therapy, right, though that provider, that therapist has to submit documentation for ongoing improvement already, as far as the patient being compliant with going to see, and then seeing an increase in whether it's mobility or strength, whatever the condition need is, so that the limitation feels, as far as authorization, feels a little bit arbitrary when it's not considering what we would expect to see. And there's already reporting in place regarding making sure that that time frame is still being utilized effectively. Is that?
yes, and then what happens in the office of the physical therapist is that they're trying to get this person moved along the curve and get them to maximum benefit, and they're stopped if they go ahead and treat them anyway, anticipating an approval. They won't be paid for their services. We've been through this, and so you have to back off. It's not a very good system.
Right. And when you're talking about something like physical therapy, where we're talking about increased mobility and strength, the continuous treatment is the more or most effective, right? When we start and stop, there is strength
Yes.
loss, there is mobility loss, there is potential need for prolonging. So this secondary or tertiary or 15 layers, if we will, of authorization for things that aren't driven necessarily by medical best practices can hinder overall recovery and extend time loss payments.
Yes, and for instance, I've had a thing brought to the medical advisory committee about a year ago where I get copied on all the correspondence with the patients. And they come in and say, well, okay, I just got this letter. It says the therapy is approved for 1 month, starting 2 weeks ago, and ends week after next. My therapist office is full because they wouldn't schedule him if he doesn't have approved appointment. So he had a 1 week window, and then we start again. That you add that up, it goes down the line. It's not good for anyone in the system.
Thank you. One follow-up question. I see the hands, but when you're talking about something like that, receiving a letter for physical therapy approval for a 4-week time frame, but it's dated, is that different MCO versus not? Or is that a
That's
standard?
usually from the MCO. But
Okay.
since we brought that up, I can't remember how we handled that, but that hasn't been an issue recently. That seems to have gone away.
Okay, thank you. Thais, I see your hand.
Yeah, I was actually just going to chime in with for people who are not enrolled in an MCO, physical therapy and other approvals don't really exist under the current rule. There's actually even some information on the WCD portal for providers to look at about what can and cannot be quote unquote authorized by an examiner, by the processing company. So for those injured workers who have an accepted claim and are not in an MCO, physical therapy, other modalities are paid based on the attending physician's direction. So if Dr. Bowman says, dear physical therapist, please schedule 3 months of physical therapy 2 times a week, or the physical therapist submits to the doctor in charge, here's our treatment plan, and the doctor signs off. For those people who are not in an MCO, that plan is what gets paid for under the rule. Where we run into authorization issues is for people who are in MCOs, and then they've got their
Yes.
contract and the MCO review of those reasonable and necessary treatment modalities.
In this model, Thais, of not being in an MCO, there's still, or maybe I'm asking Dr. Bowman, I'm not sure. I'm asking somebody to this question. When we're talking about, let's say, orthopedic surgeon is treating, but is not the attending, there's still the coordination between the attending and the surgeon as it relates to potential physical therapy or treatment plans. So there's still like a layer of multiple people who need to sort of approve and create said plan before it can go out to get the treatment the injured worker actually needs, right? Like
technically, yes. I'll be honest, I don't know a lot of adjusters are looking at, well, Dr. Bowman is the surgeon, but not the attending, so we're not going to do what he said.
So there's not,
yeah.
the way that you understand it, or the way that it is, there's a lot of rules.
Yes, there are.
This is not something that there's no rule that says plans need to be dictated predominantly or like by the attending only.
I would have to look at it. I don't have it in front of me right now. I believe that technically under the rule, those treatment plans, the referrals to physical therapy, et cetera, and especially time loss must be from the attending physician. In practice, outside of the time loss question, when there is a surgeon and a separate attending physician, I know at least the team I work with will do what the surgeon is telling us to do. And if we need to go back to the attending for any of those technical pieces, we'll have that conversation and say, hey, do you agree with what the surgeon said, and sign off on it?
Yeah, and then as same thing, I'd iterate that in my practice, when I'm not the attending, I realize that I think that most orders need to be ordered by the attending, but if I'm the specialist, just did the surgery, then the treatment, the attending's not gonna know. They're not trained in post-op, whatever was done, treatment to know what's right and wrong. And so they'll just rubber stamp what I'm going to do anyway. And then same thing with work releases. I'll take over work releases for a while afterwards, sometimes, just because I don't want them doing certain things with their arm if they had a shoulder surgery until 3-4 months post-op. So there's a gray zone there where I'm not sure what the legal statute is, but we don't seem to be having too much of a problem with that.
Yeah, this is something that I would potentially want to look into further when we're looking at access to care inconsistencies. So that's very helpful. And I do fully understand that we have rules and then we have what happens in practice.
Right.
That's something I definitely want to, and I don't ever want to look at ruling to hinder what is working in practice. When we're talking about access, I want it to be as equitable as possible. So if there is a barrier where technically under the rules something shouldn't happen or can't happen, but it's sort of happening, I'd like to fix or suggest that we fix the rule so that it can happen for everybody. So suggest, again, I don't make rules.
Oh, one of the things I meant to bring up, I don't think I did, but it would be helpful if there was a posted status of who the attending physician is and what the accepted condition is. Because patients don't know, they get confused with everything, and it can be really difficult to find out what is the accepted condition we're acting on, because it would make a difference in how we write our requests for the next stage of treatment.
Is that not in standard referral forms like demographics and new patient information that you receive when you receive a referral from an attending?
Well, there's probably a place for it, but how do we know if it's accurate or not?
Sure. So, okay.
So
That's helpful.
somebody, say a provider got an MRI and the guy's got a meniscus tear, and then he sends it to me. Well, is it accepted for meniscus tear or not? Often the treatment will go on and you find out at closure that it was not accepted for anything other than a strain. As far as things that processes that could improve the streamlining, that would be one. So it's just obvious to everybody, here's what we're dealing with now, or this one was requested and denied. You get those when there's an IME or something, but just to go along early on, that would help.
Yeah, I have that as one of the notes. Thank you very much. I see another hand. Keith?
Thank you. A couple of kind of nuances factor into what we're talking about here. One is that the insurer can approve and pay for a service without accepting the condition that's found during the service. They can approve surgeries like an orthoscopic surgery on a diagnostic basis. And we see that frequently. And then when you go in and you scope the knee or the shoulder, you find a bunch of conditions. And sometimes you find ones that you weren't expecting. And then it's the process is that the worker has to identify the conditions that they want added to the claim, and then request that, or the workers' council. And then the insurer has 60 days to accept or deny the condition. The worker doesn't when I advise workers, my advice is that if they've accepted the strain and you need surgery, and they'll approve it, I'm not going to ask for them to accept the meniscus tear before the surgery. I'm going to let them get the surgery so that I'm not prompting them to look more closely at whether they can deny the surgery. So if I was talking to my clients' doctors, I would ask them, instead of asking and starting with what the accepted condition is, start with the request. And if they deny it, then the worker knows that they need to unpack that issue. Maybe nobody wants to unpack that issue yet. So there's a lot of things regarding the initial acceptance of the claim and how far does that get you. It's different in every claim. Sometimes that gets you a surgery, sometimes that gets you a denial of surgery, and then you know you need to claim the tear or whatever it might be. The other thing is that the attending physician, the law says the attending physician is a question of fact. It's a legal question at any given time, and it's resolved based on who is primarily responsible for the worker's care. Often that shifts when we're in the surgical context, but it is very common for the surgeon at some point to say, this needs to be followed. The insurer wants this person seen more frequently than I would want to see them. They want work restrictions every 30 days. I don't need to see this worker for 3 months, 6 months, until the next MRI is done. So it's a fluid thing. It would be hard to create a database kind of to say who is the attending physician, because it kind of changes. And even if a doctor doesn't necessarily consider themselves the attending physician, if we really came down to whose orders control, they may, as a matter of law, be the attending physician, depending on the circumstances. So it is a very odd thing, but it is very fluid, and that's part of why it's fluid, and part of why it would be hard to make it more specific. The way the insurer and the doctor knows that the insurer doesn't think the doctor's the attending physician is they get a denial for that treatment, or the worker is informed that their work restrictions aren't valid. It's a clunky way to go about things, but that's important background in terms of where that stems from.
Yes, I'd like to comment on what you said about accepted conditions waiting until afterwards. The diagnosis, the preoperative diagnosis of a knee or shoulder problem, for instance, is tentative based on an MRI. MRIs are pretty good, but they're fallible. And I've had, especially in years back, where that accepted condition had to be hammered out before surgery. I've had some that it wasn't, say, a lateral meniscus tear when I got in there. That was normal. That's a common thing. And to be able, in the legal processing of the claim, to stall the accepted condition finality decision making until after the surgery is very helpful. Otherwise you're often accepted a condition that does not exist once we get in there. And whatever I see at surgery trumps whatever happened before surgery.
And the worker, if they claim the condition, has to ultimately prove that that's an accurate diagnosis, that the condition actually exists, and trying on the worker's end, trying to start that dispute or resolve that issue prior to the surgery, I tell my clients is very inadvisable. They see the MRI, they're like, yes, oh, a bunch of stuff showed up on my MRI. I want it all added to my claim. And I'd say, whoa, whoa, whoa. Let's see what the doctor thinks is important. Let's see what the doctor wants to treat. Let's see which of these conditions the doctor thinks is related. A lot of times we need more process and the surgery and things like that. And I don't think that the insurers in a lot of cases want to be out over the front of their skis accepting conditions that might not exist. I mean, sometimes the insurers, I think, let the surgery proceed just for that reason. The frustrating thing is that nobody knows after the surgery, okay, has the scope of the claim been redefined? The worker thinks that since they paid for the surgery, they own the body part that the surgery took care of. And I have to explain to them that there's multiple parts to the rotator cuff and to the knee, and no, they don't own the body part. But it's frustrating when we do get to claim closure, since the obligation is kind of placed on the worker primarily to ask for conditions to be added. If they're under the impression that what they had surgery on and remain impaired from is part of the claim, we get to closure and they find out, no, your claim is just a strain. Yeah, we paid for the surgery. We can do that, but that doesn't mean we own it. And that's a frustrating part of kind of confusion on the worker. There is an obligation for the insurer to update the claim acceptance as new information arises, but they don't always go and ask the surgeon. Sometimes they do. they don't always go ask the surgeon, okay, you found 4 different things, which of these are related? They don't always request an IME to decide if they're going to update the notice of acceptance. Hey, here's the surgical images, what's related. So sometimes it does become kind of a surprise to the worker when the next procedure gets denied. They paid for this first surgery, but they won't pay for the next intervention. Those types of issues arise and cause pinch points on our side, but you know, some of these things are part of the process, and others are things that could be improved.
Well, and two, that not, when I say a meniscus tear example we're using, it exists, but now I get in there and it's a degenerative compartment. And was it there before? Is it a pre-existing asymptomatic? Is it a combined condition? And when does that end? And try to explain that to somebody who says, I know this is from my work because it never hurt before I slipped or whatever. So that can be a tough one to work through.
Do we have any other questions? Kim, do you have anything you want to add before we let Dr. Bowman go?
I don't. Thank you.
Dr. Bowman, this was incredibly informative. I'm very grateful for your time and the extensive amount of notes that I have. A lot of this is very complex. The healthcare system is complex in general. Bodies are holistic. So I just want to thank you, and we're going to take all this.
If you have follow-up questions that come up, you know how to get hold of me. I don't mind.
Terry does.
Yeah.
Thank you so much.
All right. Thank you. Have a nice day.
All right. That was fantastic. Next up is Evo here. I see Evo.
Yes, I am. Just
Are
one
you ready?
second. Yeah, there I am. Yeah, hi, co-chairs. Thank you for having me. Ivo Trummer, Government Relations Director for SAFE. I was asked to give a little update on where we are in our process here, which I think is fitting because it was our bill, 3374, House Bill 3374, that triggered or facilitated, I guess, this endeavor here that we all been undertaking over the summer. At this point, I will say we are strongly thinking about bringing back a bill or a version of that bill for the 2026 session here, the short session next year. And I'll say it at the start, and I'll say it a couple more times, especially to a lot of my colleagues who are here on the call. We do not have language yet. It's not drafted yet, so I'm talking conceptually here. But as soon as we have language, we will share it. So our starting point, I think what we are thinking at this point is the -2 to House Bill 3374. It is not listed on OLIS. It is listed on the MLAC agenda from whatever that last March meeting was before the deadline or around the deadline. You can find that there. Briefly, what the base bill and the -2 would have done would have given SAFE the authority to own or partner with an MCO, the ability for the city of Portland to utilize such an MCO. That was at the request of the city of Portland, their fire and police, especially sort of in a separate work comp statute, if that's the correct term. And then also we had the full attending privileges for NPs and PAs in there as well. So as a starting point. We have, over the last few months, months, engaged with conversation with various stakeholders. And so here's a couple of the things we're thinking we want to change or add to the bill. One, strengthening the accountability measures that were in the bill already. We had an annual audit proposed that we would pay for, undertaken by the division, or a contract audit firm that they would contract with. We would pay for it to ensure that there is a separation between a SAFE insurer and a potential SAFE MCO, that there is no conflict of interest there. A separate board for such an entity or a subsidiary as well. And we have asked stakeholders to kind of give us ideas. Is there other things that you would like to see, additional things of sort of ensuring that separation that will give you greater assurances or comfort with that? And we are having some conversations there. We're also looking at around MCOs, and are there things that, common sense things that can be done to kind of streamline that process too, that would make it easier for workers and providers and insurers as they're potentially lengthening the enrollment time or easing the bring along provisions for provider or other things. We are also thinking of being much more explicit in the bill. It's already in the rule that any MCO can not be exclusively contracting with just one insurer, and making that even more explicit in the bill that a SAFE MCO would be open to all insurers. It could not be exclusive to SAFE or just a handful of insurers, and putting that in statute. On the flip side, we also want to put in statute to kind of give assurances to some of the MCOs in the marketplace today, do a similar non-exclusivity kind of language in the bill that would say SAFE could not only contract with a SAFE MCO, but would contract with as many as possible. Again, we are thinking of trying to work language there. What I don't know yet, or we don't know yet, and we are open to any feedback, to what degree we want to also add some provisions in there, and it's already done by MCOs today, but provisions in statute that say a SAFE MCO, for example, would do outreach to providers, provide assistance, education, right, billing assistance, helping navigate sort of the maze of what work comp is. If there is language there that could make a difference there, our goals remain the same as we're going forward. One, right, ensure resiliency in the Oregon MCO model, or the MCO model in Oregon. Remember, we used to have 15, if I've done my count correctly. We're down to 3. We just have 4 just a couple of years ago still. We're down to 3, who are all great partners to us. We want to ensure that we have a way of addressing hands-on access to care issues and delays to care, and making that on a statewide basis. And lastly, ensure that we also have a hands-on way to start addressing continued medical escalation that we are seeing in our caseload. So with that, I'm happy to take answer any questions if I can, but I was asked to provide an update, and so here we are. Once we have language, happy to share.
Ivo, thank you so much for that. I was like typing as fast as I possibly could to be able to take notes on that. I feel like these sort of fact-finding conversations that we've had have been very, very helpful in sort of identifying some common threads. And so to hear SAFE taking that feedback and looking into what needs to be added to the potential bill is very promising. So thank you. Kim, do you have anything? Any questions? I can't hear you. I'm so sorry.
Oh, I do not have any questions.
Oh,
Well,
okay.
maybe just a quick one. And well, it's just a broad question, but Ivo, do you think, in general terms, having the HB, the House Bill 3374, would it help with streamlining, some of these things that we're hearing, from the different speakers? Do you think that would help with the complexity, with the work comp insurance, help streamline some of these issues that we're hearing about?
So would it be the solution to all the issues? I don't know. Well, let me put it that way. I doubt it. It would give us the ability to kind of start addressing some of them and be hands-on, and have a responsibility there to do some of that work. The goal, I think, for all of us, every stakeholder on this call, is to kind of reduce complexity in the system over the long run.
Thank you.
I will say, right, and maybe that's not for this bill specifically, but maybe for a later endeavor for many of us, right? Dr. Bowman mentioned the letter that comes, right, and it takes 2 weeks before the letter then expires. Mailing instead of delivery in statute, right? All that could probably be updated at some point, but it will take a larger push than this effort.
Thank you.
Do we have any other questions for Ivo anywhere? I don't know who's in the room. I don't think very many people are in the room, right, Terry?
There is one guest today in the room.
Any questions? Okay, great. Thank you so much for that, Ivo.
Thank you.
Moving on to the next item on our agenda, we have a what we have heard, which is in the works. Kim, I don't know if you have kind of a list of things that we've heard. I am working on that on my end. I know that we've had a couple of conversations about that. There are definitely some common threads, a lot of them around, we'll call it documentation burden. And then delays with coordination. Those are, complex problems that I don't think are specific to the workers' comp space. I think that's the general healthcare system right now, which I know that as much as I am inspired to fix it all, I am not smart enough, nor do I have enough time to fix our healthcare system anywhere. But I do hope to see that we can make some changes. Do you have things, Kim, that you want to talk through or present or share or any of that?
I don't have anything like a real formal at this point, but the thing that kind of stands out for me a lot is the, how we can or cannot direct injured workers. I think that we need to look at that. There seems to be, I don't know if there's confusion or how it's interpreted. One of the presenters talked about in Idaho, the employers can direct their injured workers to appropriate care. And I think we have some rulings, regarding how that can be addressed. So I think that might be an area we should look at to help, injured workers get the care. I mean, first of all, it's hard to access care, but then there's this confusion of who they can even see. And I also like the idea too that, that about having more education, for the support staff. It's just with Dr. Bowman talking today about, how he had this specialist in his office and how important that was. So that might be another area, that we could address, it's just, providing some sort of certification or, education for the support staff to handle, the worker comp insurance. So those are the two things that right now are kind of like, that's something I think we could, tackle, like you said. I mean, so we're not going to be able to really, address this huge issue because it's not just workers comp, it's just health insurance in general is, really difficult, especially in the Benton County area. So anyway, that's just some of the, thoughts I have at this point.
Yeah, I would agree. Definitely when it comes to some of the reviewing of some of the OARs and ORS in relation to like how we interpret those and making recommendations on slight language shift, the word restrict versus encourage or prohibit, the language is very, very important in some of these rules. And I do think that improving the low-hanging fruit processes around getting the information to the injured worker and then, as Dr. Bowman mentioned, looking at some of the barriers around requests or referrals or auths for certain things that are like the Work Hardy program, for example, which is something I'm not super familiar with, is a great idea to submit for that. It's like I ask for an MRI, the MRI asks me if I want an MRI. I said, yes, that's why I asked for the MRI. Then you go to the MRI and then the MRI is like, did you want us to send this to the doctor? Like there's some of these back and forth correspondences that are nuanced. And I don't know, in the scope of this work and our recommendations, what we can do, but definitely at least identifying them as some problems for consideration on how we process these things, like if this, then that. Definitely looking at the best practices around things like physical therapy and follow-ups, post-surgical, limiting the amount of continued needing for authorization on such short periods of time. I mean, even something as simple as the dates switching, like in just to be very healthcare-y, in home health, when we make a recommendation, it's twice a week for 4 weeks. It's not twice a week for 4 weeks starting on 8/22. It's simply once the therapy begins, it's twice a week for 4 weeks. And something like that would then alleviate this sort of back and forth. If you have to wait for therapy to have availability for you, I understand that we've got a shortage of providers. but then you wouldn't have this extra barrier of, well, I got the letter 2 weeks late, then by the time I got there, I only got 1 week, and then I got to start this process all over again,
Mm,
because the order would be specific for the amount of time and the frequency, not necessarily the dates of service. And so these are things that I'm hearing regularly, and then also just some additional accountability around responses.
mhm. Yeah.
What that's going to look like, right, is going to be difficult because everywhere is short staffed, but the need to get a response quickly, to be able to move forward or to look at other processes, like, seems to be in every provider that we've spoken to a common issue. And that is something I definitely want to hopefully make recommendations on how to improve that or increase
Mhm,
accountability on that from the whomever
mhm,
whomever is handling the claim. Keith, I see your hand.
mhm.
I don't know if we're allowed to ask questions or make comments on kind of what we've heard. Is that okay? I mean, just briefly, I mean, the thing that I heard, I think is a common thread, was one, the administrative burden and how that translates into a cost burden and makes, I think Dr. Bowman said it was 20% more of a burden on comp than it is in the
Mhm.
private health insurance. So I've heard a couple times that it's just bad all over. Well, I heard that it was 20% worse in workers' comp, and that seems probably pretty significant to the bottom line for some of the providers. So it seems like actually when we did the hassle factor study way back many years ago, SAFE did a study, and that was one of the things, is that the reimbursement needs to account for all the extra work that is done, so it's comparable at the end of the day. The other big common thread that I heard is that the doctors aren't getting timely responses from the insurers, and we can kind of couch that in terms of administrative this and that. The bottom line is that that's hurting the worker and hurting the doctor and costing the employer more at the end of the day, and leading to a worse medical outcome. So, I mean, in my mind, the proposal that I would kind of like to see is kind of, as we were alluding to this morning, some sort of standardized portal where we have a paper trail as to when the request was sent and who it was sent to, and then a deadline for a response to those requests. And it's our position that if the deadline is missed, then the service should be paid for. We've got a paper trail that it was submitted, it was not responded to within the period. The worker and the doctor should be able to move forward without hounding for a response. So kind of an open fail safe, so to speak, is something that we would really like to see in the process here. And timelines in general. When I talk to my clients and they say the doctor can't get a response, I say, well, did they send a fax? Did they send an email? Did they have an email to send it to? But did they send an email? Can you get me something in writing where the insurer has, not responded? It seems to me, along with the education, we could educate them on a streamlined process, like I'm describing, that gives them more ability to submit it once and then not have to keep following up, hearing from the patient, following up, hearing from the attorney, following up. I can't imagine practicing medicine in that. I tell my clients, when I tell them how few doctors are involved in the system, I say, there is no way in hell I would treat workers involved in this system if I was a doctor. If I had any choice, no way, unless I just had the biggest heart in the world and that's what I was going to do as a mission. You'd really have to be mission driven to wade into this, I think. Thank God people do, but it wouldn't be me. That's all I got.
Thanks, Keith. I see Lon, right? It says iPhone 16. I was just guessing.
Sorry about the delay. Co-chairs, there has been a discussion in the past regarding directed care from employers to help injured workers, getting them an expedited care. There's several issues and a lot of work that's been done around this in the past. And I'm sure the department has a lot of the testimony and data that regards this issue, including a company nurse for treatment, depending upon the severity of the injury, whether they're directed at that point to an emergency room or to some kind of other physician that may be out there. And the lists that are compiled for who would be selected and where the direction would be imparted upon the injured workers. And it all varies. I mean, if you're a farmer in Eastern Oregon, it's different than a major corporation within the state. So I would just ask the committee to take a look at that past data before they consider any type of directed care, because there's been a lot of work already done about that issue.
Good to know.
That's really good to
That's good to know.
Well,
Yeah, thank you.
Thanks.
Kim, you have anything else? We're sort of, just finishing in the fact finding, it feels like, portion of this subcommittee. And so a lot of this information, I think, needs time for processing, for us to begin to formulate and review some policy and OARs and make some recommendations. So I think it's ongoing, I guess, is what I'm roundabout trying to say. But I want to check with you, Kim, before I move on.
Yeah, I mean, yeah, it's been really helpful to hear the presentations and to get like a better idea of what they're dealing with firsthand. Generally, I also think a big problem is just we have an aging workforce. People are working longer, and with age comes more health issues. And as Dr. Bowman was, talking about, you have these pre-existing conditions, and then you have a work injury on top of that, and then how it all has to be sorted and divided, and it's just, this injured worker becomes, just body parts. We kind of lose the whole person, and with how we treat, how we treat some of these worker comp injuries. So I don't know. I just think that I don't know how we're going to address that, but it's, this is the system we have. But I just think as we get more people working longer, this is going to be more of a problem.
I think that's a really good point. Looking at my background in nursing is a very holistic care setting. And so looking at patients as diagnosis codes, especially as body parts, and trying to defer and cipher out what percentage is this or that, sort of grates against, admittedly, my own like clinical background, but I fully understand the necessity to look at a system from this sort of sectioned off operational standpoint, because there's no other way to do it, right? We have to parcel ourselves out to figure out what percentage. And that is in its own right incredibly complex. I mean, I've done some medical coding and billing, and even in a holistic care setting, it's complicated as to what medications are medically necessary versus related versus palliative. So I just want to address that. Like, I agree with you, and it is not probably a problem that is going to have a clear black and white solution. We're going to try and, do our best, but I see a hand.
Looks like C. Frost. I see that.
Yes, Chris Frost, Oregon Trial Lawyers. I really appreciated Lon Holstein's comments about the employer recommending and care, because in 2011, yeah, there was a lot of work done to, and maybe Stan Fields can be helpful in this regard, because as claimants attorneys, we sometimes get workers who come to us whose employer has violated the restriction from directing care. And honestly, it's usually what they've recommended it is not helpful to the worker. So while it might seem like a possibility, I think it has proven to be fraught to have the employers take that on.
I appreciate that. I think that in reviewing the statute, I just want to kind of highlight that, again, looking at the intent and maybe getting some clarity around language, but I liken it to the preferred providers. I'm not suggesting in any way, that we restrict workers' choice. I just think that navigating the healthcare system, even as somebody who is in healthcare, is already complex enough. And so to be able to provide additional resources to workers to be able to feel like they're making educated choices is something that I think would be very beneficial. So it's really looking at intent of language and making sure that the intent is for the best interest of an injured worker. So
Yeah. Right. I agree. I mean, it's not to explicitly say where they have to go, but it's at least giving them some options. I think sometimes it's just, yeah, just giving them, some information would be helpful.
yeah, it's looking at the idea of being able to increase the amount of available information for providers that are in the area. Again, the way that I read the statute, it talks about not being able to restrict right of choice, but I'm still looking for clarification on that and doing some additional research on that. So is Terry in the room?
Diane.
Oh, you disappeared from the owl and I was worried.
Yes, I'm here.
Do we want to move to public comment? Is there anything? I appreciate you helping facilitate, so I just want to check with you before I start steamrolling through this agenda.
We can move on to public comment. You have the agenda in front of you, or do you want me to help you with that?
No, I do. I found it because you sent it. That's how I found it, by the way. So for public comment, we have Steve Bennett from APCI.
Hi, everybody. Thank you. I'm with the American Property Casualty Insurance Association. I think I just want to lead off my comment from thanking everyone on this subcommittee. I think we've gotten a lot of valuable information, and I think we've learned a lot, and we're tackling a very important issue, which is access to care. In many respects, the insurance company, I guess, is the punching bag to many comments so far that the problems lie with the insurance companies. I of course disagree with that, and I just want to state, thank you. We want to know what the problems are, and we want to fix them if we can. We want workers to have access to care, and we want them to get healthy as soon as possible. It's in everyone's interest, the injured workers, the insurer, and the employers, that workers get the care they need, get it quickly and efficiently, and that they get back to work at an appropriate time. That I think there's been a lot said that's very beneficial as far as delays, administrative burdens, non-responsive, the need for deadlines, and the insurance industry will be glad to work on these issues. We want the Oregon medical work comp system to work well and to get workers the medical care they need. So I think this subcommittee has been very valuable, and it's done a lot of work that we appreciate, and we want to continue serving on and see what we can do and see where we can make a significant improvement in the system and in the aspects that it needs help on. And I would agree that some of the burdens and deadlines could hopefully be fixed with some solutions. One thing I did want to comment on, the not trying to attack SAFE or anything, but we would oppose, as the insurance industry, any proposal that would allow SAFE to operate an MCO. Private insurers are not allowed to operate MCOs. It's in the statute as is. SAFE already has many competitive advantages to the insurance industry. They do not have to pay federal and state taxes like we do. They are not in the guarantee fund like we are. Many of the regulatory controls that apply to insurers do not apply to SAFE. The governor appoints their board of directors. A lot of states that have these public work comp insurers, the public work comp insurer also acts as the employer of last resort, as the residual market. SAFE does not do that. SAFE participates in the assigned risk, but the private insurers equally work in the assigned risk program. So that proposal that's being offered by SAFE would just provide one more competitive advantage to SAFE. Due to their competitive advantages, SAFE already controls over 50% of the work comp market. So we would think any proposal that would increase their competitive advantages is extremely problematic. Currently, the work comp system is kind of a tripartite system with SAFE, private insurers, and self-insurers. We would not support a proposal that, you know, helps SAFE, but does not really impact self-insurers and private employers who use private insurers. So I would just want to emphasize that while insurers definitely want to see good access to care and help in defeating, you know, these delays and administrative burdens and to impose deadlines if appropriate and proper, but we cannot support proposals that would give SAFE one more competitive advantage to private insurers. Thank you.
Thank you, Steve. Moving on to Chris Frost. Chris, I don't know if you already gave me what you wanted to say.
Yeah, I don't have any formal comments. Thanks a lot. You guys are doing a great job by vetting all this stuff.
Well, thank you. I realized that you had already spoken, so. Any public comment in the room, Terry?
Did you want to sing? No. Okay.
Okay.
No.
Well,
Coach,
go ahead, I'm so sorry.
one thing real quick. Our next meeting is September 12th, Friday at 9 a.m. So I just wanted to give everybody a reminder.
Thank you.
Thank you so much, Terry. Well, if there's not anything else, I want to again thank everyone's time and attention. Incredibly great information. My head is swimming as is usual at the end of each of these meetings. I am super grateful for the opportunity to participate in any solutions that we can make recommendations for to increase access to care and support injured workers. I'm very proud of the work that we're trying to do. And that is all I have. Kim, do you have anything before we let the world go?
I don't, yeah, just to reiterate to my, you know, gratefulness for everybody's participation and just, you know, openly sharing, you know, their thoughts and providing, you know, information. So, and all the behind the scenes work that is done by Terry and her staff, really appreciate that as well.
All right. Well, everyone have a wonderful rest of your day and thank you again. Stay clear.
Thank you. Bye.
Great weekend.